Hi everyone, welcome. Thank you for joining us today for this RCNI webinar, Identifying and Managing Sepsis, a Nursing Update. I'm Sophie Blakemore. I am the editor of Emergency Nurse Journal and co-editor of Nursing Management Journal, and I'm delighted to be chairing this event. For those of you who don't know, RCNI is the publishing arm of the Royal College of Nursing. We are editorially independent and we publish 10 journals online and in print annually, as well as hosting a range of events, webinars such as this one, jobs fairs, podcasts, and our flagship event, Nursing Live, which is taking place in Liverpool in October this year. And during the break later on, there will be a QR code, put up on the screen. And if you scan that, you'll be able to find out more information about that. It is a free event for nurses to attend. Now, getting on to the subject matter, some of you might be aware that September is Sepsis Awareness Month, so it seems very apt to be hosting this event today, especially following the nice updated guidance which was released in March earlier this year. As editor of Emergency Nurse Journal, I commission and publish a lot of content on sepsis, particularly identifying and managing it in the emergency department, which will be covered today. But I'm really pleased that we've got such a broad focus today in this webinar. We're covering a lot of events. We've got a lot of great speakers, and we will be looking at the deteriorating patient and how to recognise and manage them in the community and hospital. The blood culture pathway and the importance of getting that right. The new sepsis guidance, there'll be an overview of that. And also we're looking at survivorship and Martha's Law and what that means for you as nurses in your practice. We will have a 5-minute comfort break halfway through this 2-hour session, and then at the end there will be a panel discussion and Q&A session. So please, if you have any comments or questions, please do add them into the Q&A box as we go along, and they will be moderated by our team, and we'll do our absolute best to answer as many of those as possible at the end. Just to let you know that this webinar will be recorded and will be made available on our on-demand website shortly after the event, so you can go back and watch it at any time or share it and promote it amongst your colleagues. We have got some really great speakers lined up for you today. I'm really excited to get going with this. But before we crack on, I'd just like to thank our sponsors, bioMerieux, who have made this event possible. So thank you very much to them. So now it's my great pleasure to introduce our first speaker, Suman Shrestha. Now, Suman is, for those who aren't aware, is the RCN professional lead for critical care, and he's also a nurse consultant at Frimley Health. He has done a lot of work on improving sepsis care, both in his own trust, locally, and at national level. He's a bit of a bigwig when it comes to sepsis, and he's going to talk to you today about the new NICE guidance and the guidance from the Academy of Royal Medical Colleges. So Suman, over to you. Thank you.
Thank you very much, Sophie. Hello there, yes, I'm Suman Shrestha. So in this presentation, what I like to do is give you a basic overview of what sepsis is, and we'll discuss some of the data around sepsis, and we'll also discuss the definition of sepsis itself. And I'd also like to talk about the treatment strategy for sepsis, particularly on the initial stages as well. And I'd like to focus particularly around the antimicrobial management following the Academy of Medical Royal Colleges and also the NICE guidelines. Well, sepsis is a complex syndrome. Patients present with non-specific symptoms, and if you don't treat them in sort of early fashion, if you don't recognize them, then they can deteriorate and potentially die from it. And it is a global crisis. So it is estimated about 47 to 50 million patients are actually affected by sepsis around the world. And around 11 million people die from it, which is equivalent of 1 death almost every 3 seconds. And hence, the World Health Organization back in 2017 actually declared sepsis as one of the global health priorities. And in the UK, it is estimated about 918,000 admissions actually takes place regarding sepsis, making it one of the common causes leading to hospital admissions. And about 66,000 people die from it. And it also costs the NHS in England about £2 billion to treat sepsis. And we know from the Just Say Sepsis report, which was published back in 2015, that patients present with huge variable of clinical presentation when they arrive in hospitals. And we also know that 75% of the patients actually develop sepsis in the community. But it also highlighted that not all the patients actually receive good care. In fact, only 36% of the patients actually receive good care. Next slide, please. And you'll see a lot of stories in the media regarding sepsis. And unfortunately, predominantly, it's quite a negative story. And the stories are quite tragic. But it does raise some public awareness as a result of all these stories published on the media. But on the other hand, it also causes a lot of anxiety with our patients. And you can see that when you actually speak to patients and relatives, whenever you mention a word sepsis, there's a bit of a dread in their look. And there are a lot of work has gone around sepsis. And I've already mentioned the NCPOD report, but there's also NHS England have published some guidance around it, but also Surviving Sepsis Campaign guidelines, the NICE guidelines and the new definition. And also there has been a publication around sort of all-party parliament group on sepsis. And recently, the Academy of Medical Royal Colleges published a position statement on initial antimicrobial treatment of sepsis that was published in 2022. And I urge you to read this. There's a lot of good work has gone into this publication, and there are great references at the back, those of you who are doing some work on sepsis. And this year, the NICE guidelines was published earlier, which was the revised guidelines from back in 2016, which actually reflects quite a lot of recommendation from the Academy of Medical Royal Colleges. And I'll be discussing that a little bit later. So what is sepsis? The definition of sepsis was published in 2016, and this is the third, following the third sort of version. And the definition is that sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. And next slide, please. And how do you explain that? And how do you explain that is that in order for us to diagnose sepsis, the first thing you need to have on a patient is infection. If there is no infection, it is not sepsis. And a lot of the time, infection is quite obvious. For example, if you got a patient with a chest infection, they might be coughing, and they might be short of breath, and so on. But sometimes, for example, intra-abdominal sepsis are not easy to diagnose. In this sort of situation, you can take patient's history, and patient's examination can help you to have suspicion of sepsis, and that is good enough. And for some reason, we don't, sorry, can I go back to slide, please? For some reasons, we don't really fully understand. In some patients, it could be genetic, their immune system responds differently, and their immune system have this exaggerated response, which can lead to organ dysfunction, which can, if not treated very well, can be life-threatening, and that is what sepsis is. And when they redefined sepsis back in 2016, they also looked at the definition of septic shock. Now, previously, we used to think that somebody who's got sepsis and they're hypotensive, we used to think that they have got septic shock, but actually the definition has changed. There are two key clinical criteria that we need to look at to define septic shock. The first is hypotension, requiring vasopressor. So these are the drugs to actually elevate blood pressures to maintain mean arterial pressure greater than 65 millimeters of mercury. So these patients have basically got a low blood pressure, and they are requiring drugs such as noradrenaline, phenylephrine, and that sort of drugs to maintain their blood pressure. And the second clinical criteria is that we look at the lactate greater than 2, and that is despite adequate fluid resuscitation. So you need to meet these two criteria to be able to say or diagnose that patient's in septic shock. And when we looked at the guidance for from the Academy of Medical Royal Colleges, we also looked at the terminologies. And what we're now encouraging people to use the terminologies like infection, non-complicated infection, if the infection is not actually causing too much of a problem for a patient, right? And sepsis and septic shock, these are the terminologies that we are now encouraging our healthcare professionals to use. And we're trying to move away from these redundant sort of terminologies like SIRS, severe sepsis, because the new definition of sepsis is actually what the severe sepsis is. And we're also moving away from encouraging healthcare professionals not to use terminologies like blood poisoning, because that does mean very, very horrendous and doesn't really have a real meaning to what sepsis is. And we know that pneumonia is the most common causes of sepsis. And the NC report, 51% of the patients included in this report had pneumonia chest infection. And UTI, urinary tract infection, was the second leading cause, followed by the abdominal infection. Now, if you look at the literature, UTI and abdominal do tend to swap places depending upon which literature that you look at, but they're generally on the second and the third place. And then the last one is the soft skin tissue infection. These are your cellulitis, the necrotizing fasciitis, and that sort of skin infection was the fourth causes of sepsis. Sepsis affects all ages. Sepsis affects young, healthy individuals. Sepsis affects rich people as well. So sepsis is actually common in all ages. And we don't really know why sometimes even the young, fit, healthy individual can actually develop infection and become septic and potentially die from it as a result of that. And there are a lot of studies going around looking at the genetic factors around this, and that could be the reason, but at the moment, we just don't know the true answer to that. And when you look at the data, what we do know is that the number of admissions related to sepsis is higher in our elderly patients and the youngest, between 0 to sort of 40 years of age. But if you look at the mortality, can I have the next, please? If you look at the mortality, the 77% of the death occurs in the patients who are 75 years and over. So our elderly patients are really, really vulnerable from dying from sepsis. And what are the risk factors associated with sepsis? Well, there are patients who are diabetic, the patients with impaired immune systems, for example, those who are receiving chemotherapies, patients in intensive care, with endotracheal tubes, catheters, central lines, PICC lines, those patients who recently had an organ transplant and they're in sort of immunosuppression drugs, patients with liver failure, liver disease, kidney disease, post-operative patients who's recently had surgery, pregnant and postpartum stages up to sort of 6 weeks, and those patients who've got wounds and burns, they are at risk of developing infection and sepsis. But the good news is that from intensive care data, that the mortality of sepsis has actually been in a decline over the years. And we have also seen a similar pattern globally as well. I think this could be because there has been a lot of investment gone to recognize sepsis and also treat sepsis in early stages. So this is the international global study looking at the incidence of sepsis. There's been a fall by 37% on the incidence globally, and there's been a mortality decrease of about 52% from between 1990 to 2017. And sepsis is time sensitive. Early detection of clinical deterioration is absolutely key. And the nurses play a vital role on this, not just nurses, but also healthcare support workers as well, because we are usually at the forefront of managing these patients or seeing them before they deteriorate or while they're deteriorating. And the problem with sepsis is if you compare sepsis with other leading causes of hospital admissions, for example, MI, myocardial infarction, the presentation is quite clear. Patient will have classic symptoms like chest pain. Population is very well described. If you're a middle-aged man, you are at risk of developing myocardial infarction. And we also have a bedside test that we can do. We can do troponin, we can do echo, we can do imaging, like we can do angiogram. So diagnosis can be easy. But with sepsis, the presentation can be really, really non-specific. The population, sepsis can any age group of people can be affected by sepsis. And we don't really have any bedside tests to actually determine the diagnosis. So this is why it is really difficult to recognize sepsis, particularly in the initial stages. And there is a lot of political drive around improving sepsis over the years. And this is from the American studies that they introduced a lot of incentives to improve sepsis. And they saw a huge amount of rise on the coding of sepsis. And some potentially is saying that this could be the overdiagnosis of sepsis. And this is because if you run the slides, please, if you look at the infection, they actually, the data on infection has been really static, but the coding has gone up. And also we saw the similar thing in England. Can I have the next slide, please? In England, there was an introduction of a sequin back in 2017. And this, when sequin was introduced, suddenly we saw a big spike on the diagnosis of sepsis. And the problem with that is what we've seen was the rise in the use of antibiotics too. So what's the problem with that? Well, rise in antibiotics use, can I have the next slide, please, is associated with antibiotics resistance. And we're already seeing this. There's been a rise of 4% incident on antibiotics resistant infection. There's also a rise in a number of patients dying from it too. So it's a problem. As a result of that, World Health Organization actually declared, again, antimicrobial resistance is one of the potential problems for the future. And Sally Davis, who used to be our chief medical officer, who is active in this arena, has actually warned that this could be a big problem and may make COVID look like a minor problem. So antibiotic stewardship is absolutely key in order for us to save these antibiotics. And we've been talking about the treatment for sepsis, and most of the focus has been around antibiotics, the timeliness of antibiotics therapy. And the recommendation has been giving antibiotics within an hour. But there's been a lot of studies recently looking into this. And this meta-analysis actually did not find an association between early antibiotics delivery and patient outcome. And then this has led to looking at the guidance in detail. And the Surviving Sepsis Campaign, who published the guidance 2021, was the first to actually comment on this and publish a guidance around the initial antibiotics therapy. Now, what they've said was in this guidance is that if the patient has definitely got sepsis and they are in a shock state, then that group of patient definitely needs antibiotics within an hour. But if the sepsis is possible and the shock is absent, now the next slide, next please, possible, and shock is absent, then what we should be doing is we should be focusing on rapid assessment of this patient and trying to understand where the infection is coming from. And we should be administering antibiotics within 3 hours. So as a result of that, the academic medical royal colleges were asked to provide a positioning statement on initial antimicrobial treatment of sepsis, and a group of people led by Professor Bjorn, actually we published this guidance, which I'm going to just to discuss with you. Next slide, please. So this is basically, if you go into the guidance, you'll see this chart, which actually gives you the overview of what the guidance is. And I'll just like to talk you through this. So physiology first. We should be using the NEWS2 score to risk stratify where the patient is. So for example, if those patients with a NEWS of 7 and above should be at a high risk, NEWS of 5 and 6, moderate risk, 1 to 4, low risk. And the initial assessment and generic action should be same as what's been recommended by the Royal College of Physicians News 2 guidance. But this is the bit specifically for the antibiotic management. So once we've done the news, with News 2 score, we should be looking at the clinical likelihood of infection. If it is unlikely, if the infection is unlikely, then it is not sepsis, then we don't need to really move further. But if the infection is possible or probable, and the patient's news score is between 0 to 1 to 4, they are at low risk. So we can actually treat patients within 6 hours. But if the patient's news score is 5 and 6, and their infection is possible and probable, then we have a window of 3 hours to give antibiotics to these patients. Now, if you know that the patient's deterioration is due to infection, by all means, give antibiotics as soon as possible. But if it's uncertain, then what the guidance is now, both from the academic medical royal colleges and the NICE, is that use that 3-hour window to actually get senior clinical review and also have some diagnostics to determine the cause of deterioration is infection. So the only patients then who should warrant antibiotics within an hour is those patients who has got news score of 7 and above. So this is what the guidance is. So this is what the NICE guidelines replicated into the new version of NICE guidelines, which was published earlier this year. But it's not just about initial antimicrobial sort of therapy or initiation of therapy. It's also about continuing antibiotics. So in clinical practice, we obviously prescribe antibiotics, and the patients receive antibiotics through, sometimes just on a drip, for example. Give an example of metronidazole, for example, should be given within 20 minutes. But if you prolong that duration, then it's not going to be effective. And same with the duration, not the duration, the frequency of antibiotics as well. It needs to be administered in timely manner. If you don't, the effectiveness of antibiotics is not going to be as same as when it's been administered in timely manner. And apart from antibiotics, there are other things that we need to focus on as a part of the treatment for sepsis. Giving oxygen to patients who are hypoxemic, aiming for saturation of 94% and above. And those patients who have got COPD, we need to be a little bit careful and aim for saturation between 88 to 92%. But these patients might need further care and further support. They might need non-invasive ventilation. They might need high flow oxygen. They might need intubation if the respiratory function and respiratory failure is severe. I know we've got a session on blood cultures later on, but we'll look at, sorry, can I just go back one slide, please? But we also need to look at obtaining blood cultures, particularly before giving an antibiotics. And when we think about blood cultures, we should also be thinking about getting samples from urine, sputum, any wound, and so on. Antibiotics is the key for as a treatment for sepsis, and which is really, really important. And what we're now encouraging people to, healthcare professionals, to do is to use specific antibiotics if known source of infection, using tools like MicroGuide. Measuring lactate. Lactate gives us a really good indication about how sick the patient is, and not just measuring one-off, but also having serial lactate, just to see whether the patient's improving or not. Fluid challenge is really important, particularly if the patient's hypotensive and hypovolemic, and we encourage you to give crystalloids to maintain, if the patient's blood pressure is less than 90 millimeters of mercury. Measuring urine output is, again, very important because 30%, 40% of the patients with sepsis can develop AKI. Next slide, please. And source control is also really, really important. Those patients, particularly if they've got intraabdominal fluid collections, if they've got necrotizing fasciitis and a wound and so on, source control is really, really important as well, part of the treatment, which has been now recommended by the Surviving Sepsis campaign. So next slide, please. But it's not just all about clinical management. We also need to focus on our healthcare workers. So again, I've mentioned earlier about healthcare support workers being one of the first, probably in the hospital settings, to be seeing these patients. So we need to have a education and competency framework for our healthcare support workers. Next slide, please. And we know that our nurses in the wards are actually tackling loads of multiple clinical priorities, and sepsis is only one of them. So we need to have a little bit of empathy towards them as well when we are actually driving some of the QI projects. Next slide, please. And safe staffing is really, really important. Again, we've got plenty of evidence to say that hospital that has fewer staff to patient ratio do really well, right? In compared to those areas who have got higher nurse to sort of patient ratio. And so, in other words, one nurse looking after lots of patients. And hence the RCN have actually been campaigning now around safety critical profession and introducing this nurse to patient ratio, because we now know that, from the evidence that when you compare 1 to 6 nurse to patient ratio versus 1 to 10, mortality is about 15% lower in a nurse to patient ratio when it is 1 to 6. And this sort of ratio already exists in childcare and animal kennels, and we're campaigning that actually we do that similar in our hospitals as well. And we already know that nurse staffing standards is again really important to drive that forward. But managing sepsis and improving sepsis takes also buy-in from really senior level. So this is our World Sepsis Day picture from 2 weeks ago, where we actually got all our board members to actually hold up the placard, and also we spoke with them about what sepsis is, and also we discussed our care quality accounts with them. And so the sepsis is actually in our radar and a board level, and this is what you need, really. You need to have a really board level engagement, and also the engagement from our doctors and nurses on the ward level as well. And this is my final slide, just to give you a final thought on sepsis. So this was a quote from a philosopher back in 1400s, who said that hectic fever at inception is difficult to recognize, but easy to treat. Left unintended, it becomes easy to recognize, but difficult to treat. But here we are, 600 years later, sepsis still is difficult to recognize in early stages. And if not treated or recognized, then it becomes very, very difficult to manage later on. So in order to improve the care in sepsis, we desperately need diagnostics. At the moment, the diagnosis is purely dependent on clinical judgment. We need to continue education and training of our staff, but most importantly, I think we need to save staffing in our ward areas, in our A&Es, or all the clinical areas. We need staff who are appropriately trained, but also in appropriate numbers as well. Thank you.
Thank you, Suman. That was a great quote to end on. That was a really comprehensive overview, thank you, of sepsis and what led to the change in the guidelines. We did have a few questions coming through actually for you, but we've got time for one now. I can try and get to some more later. But how do you balance aggressive fluid resuscitation with risk of fluid overload in patients with pre-existing conditions such as heart failure or renal impairment? That was one question that came through.
That is a really, really good question. And this is where, taking appropriate medical history is so important before treating the patient, and also giving patient individualized care as well. So because the guideline says that give fluid resuscitation doesn't mean that you just give fluid without without taking consideration of what the patient's medical history is. And there are other strategies that you can use, like you can use passive leg raise strategy if those patients who are really high risk of developing potential, pulmonary edema as a result of the fluid challenge, you can do that. But the key is that take a good patient history and give patient individualized care.
Right. Thanks, Suman. That was brilliant. Right, our next speaker is Sian Anakin, who is another font of all knowledge when it comes to sepsis. Sian is deteriorating patient lead at Dudley Group NHS Foundation Trust, and also a communication officer with the UK Sepsis Practitioner Forum. She's also involved with the UK Sepsis Trust and was co-author of the UK Sepsis Trust Sepsis Manual, the 5th edition. I actually recorded a podcast on sepsis with Sian last year, so please do go and give that a listen. She really is very knowledgeable. And she's going to talk about how to spot a deteriorating patient in the community and in the hospital setting. Thanks, Sian.
Hello, everybody. Nice to be here today. Thank you for asking. I'm going to be talking a little bit about how to spot a deteriorating patient within the areas of the community and the hospital perspective. So if I can have the next slide, please. Looking at the learning objectives for this, we are going to use the PEER framework, which is prevent, identify, escalation and respond, because that frames a really nice format for looking at any kind of deteriorating patients, not just for sepsis ones. So I'm going to be looking at understanding the importance of the early recognition, and then how we can use some simple measures like look, listen and feel and ABCDE structure to actually use that, because we don't always have access to the ability to take vital signs, but we can still use structures for this. So it's then thinking about who to call and when we actually want that help, and how we can respond as well. And while we're waiting for that expert help, is there anything that we could be doing alongside that? Next slide, please. So the Resus Council UK has a chain of prevention, which is a really nice chain to look at for any type of deteriorating patients. It always starts with education for your staff, but also education for your patients as well, because we need to empower them in the first place to know when to call us. So it's thinking a little bit about educating your staff and educating the people you work for in how to actually monitor those patients. So what do we do when we go and see them? How do we monitor? How do we document that? How can we enable the people who are coming in after us to know that this is a deterioration from what we've seen? It's thinking about how we can recognise that deterioration as well. And sometimes it's not quite as easy as it can be. We've already heard that sepsis is not the easiest thing to recognise, and we can be needing to look at the soft signs as well as the normal ones we'll pick up in the early warning score. It's clearly knowing when to call for help and who we can actually call for help as well, and what sort of response we can get. And that response and all of these links in the chain are key in reducing the predictable and preventable deteriorations that we have around our hospital and community. In reducing those predictable and preventable deteriorations, we can reduce the length of stay, we can improve our quality of care for our patients, we can reduce mortality. So all in all, we reduce the cost of deterioration in the NHS, and that can provide extra money for other things. Sepsis in itself costs more to the NHS than looking after asthma. So we know that this is an absolutely huge subject that we need to be looking at. So if we can move to the next slide, please. As I've already said, if you're in the community, or even if you find somebody deteriorating in a corridor, you don't always actually have the ability to have a nice set of equipment around you. You might literally have your eyes, your ears and your hands. So in order to identify, it is using some very simple techniques of look, listen and feel, but then also using a very simple structure. Everybody knows the first 5 letters of the alphabet, and as I came about from a resus officer, I'm pretty good at the first 5 letters, and it's not just because that's as far as I can get, but actually as an airway problem is going to kill me before a breathing problem, and a breathing problem is going to kill me before a circulation problem. So it's really important that we look for those issues and then try and treat them before we move on to the next one. Can we have the next slide, please? So thinking about going in and seeing your patient, whether you are in the hospital or whether you are in the community, in somebody's house or in a GP surgery or nursing home, the first thing you do without even realising is you're looking at your patient. You're getting that first impression, you're getting your gut reaction. You're seeing, without going any closer to them, whether they look like they're in pain, whether they're sweating, whether they look really agitated or anxious. You can see by their demeanour and their how they're holding themselves, whether they're working really hard with their breathing. And it's using all of those first impressions to actually shape what you're going to do next. So looking is actually the very first thing that you do, and that's how you start to triage your patient. And it's making sure that actually this is one of the worst documented bits of our observations, because we don't always think about writing these bits down because it doesn't fit necessarily in an early warning score. So it's making sure that you've documented what you saw and why you had that first impression really well in your notes afterwards, because that can be key for the next practitioner coming through to identify further deterioration or improvement. Next slide, please. When you look, you're also going to listen. So potentially, again, before you've even got any closer to your patient, you're probably going to introduce yourself, or hopefully going to introduce yourself. Hello, my name's Sian. I've come to see you today because. And actually, you hope that they're going to respond to you. If they respond and they talk normally and there's no other abnormal noises, you probably don't think anything else about listening. But if as you're walking in, you can actually hear some abnormal noises, so you can hear a wheeze, which might be an inspiratory wheeze, which we'd call a stridor, which would be like a high-pitched inspiratory noise, like the wind whistling around between the buildings, sort of a then that's indicative of an obstructive airway. Or it might be more of an asthma type wheeze, which is an expiratory wheeze. So as they're breathing out, you can hear that wheeze. You might have somebody who's got sort of really abnormal breathing pattern or really abnormal sort of coughing pattern, and it's just finding out whether they're actually choking or what's going on with that. And it's obviously thinking about sort of gurgling noises would be an indication of sort of fluid in that airway. And if they're snoring, is that because they are asleep and they're naturally snoring, or are they snoring because their airway's actually partially obstructed? So it's thinking about, if you can actually hear something, that should be ringing alarm bells and just making you think, what am I hearing and why am I hearing it? Can I have the next slide, please? So that's the look and the listen. And then it's thinking about the feel. You've got your hands with you before you've got any equipment. So there's lots of things that you can do and you can find out about your patient before you even put any equipment on them. When you actually do a set of observations and you shake their hand or you feel their pulse, you've got an indication of their skin temperature. Do they feel warm? Do they feel cold? Do they feel clammy or sweaty, or does it feel really dry and hot? It's thinking about, can you actually feel some swelling or edema? Can you feel crackling of surgical emphysema? And if you're actually looking at their lung expansion with your eyes, feel it as well. Put both hands on the chest and feel whether your hands are moving bilaterally and symmetrically. Are both lungs using the same sort of volume? And that's much easier to tell by actually having your hands on the chest and letting them move apart with each breath, rather than just trying to judge by eye. And by doing that as well, if the patient has a lot of secretions on their chest, you'll feel that rattling underneath your hands. So you may not have the ability, the equipment or the skills to actually auscultate the chest and listen to their breathing, but you have got the ability and the skills to put your hands on that chest and feel that those secretions rattling and know that actually somebody else needs to auscultate that chest. So it's working within the bounds of your skills and the bounds of the equipment that you've got available to you. Have the next slide, please. And then it's using a nice structured approach. We've already said that an airway problem is going to kill you before a breathing problem. So the first thing you should be doing when you approach any patient is actually speaking to them. It's just that, hello, my name is, and it's that good morning, just that greeting. If they speak back to you, then you're actually probably just going to ignore the fact that you've just done an airway assessment, because their airway is fine. They're able to talk, their airway is patent, and you've not heard any abnormal sounds. So you'll just carry on with whatever you went in to see that patient for. However, if they can't speak to you, or if you have got those abnormal sounds, or if there's no sounds at all, then that's the point that you need to be considering. Do you need to actually do something? Do you need to do something simple like a head tilt chin lift? Do you need to get some extra help so that you can have some adjuncts like a nasopharyngeal airway or an oropharyngeal airway? Do you need to be starting oxygen? And if you are thinking about starting oxygen, it's remembering that that needs a prescription. So you can start emergency oxygen via the high flow mask at 15 litres, because that's listed in the British Thoracic Society as an emergency. So you can start that without a prescription. Same as you can start the 15 litres via a bag valve mask if they need respiratory support. But it's that important question, do you need help? If there's any airway issue, then you need help at this point. You don't need to do the rest of your assessment. You need to be making sure that help is on its way. If you're out in the community, that's going to be making sure that you're actually getting that 999 call, because you're going to be waiting for that ambulance service. If you're in the hospital, it's pulling that emergency buzzer. It's making sure that people come to you rather than you leave that patient. When you pull that emergency buzzer in a hospital, the whole world descends upon you. So you can make sure somebody else has the instruction to go and call 2222 and put out that emergency call, but to come back and tell you that they've done it. And likewise, if you're asking somebody else to call that ambulance, get them to come back and tell you when they've done it. Next slide, please. So if you're happy with that patient's airway, then you're going to have a little look and assess of their breathing. And that's going back to that look, listen and feel structure to structure your assessment. It's thinking about counting that rate of breathing. And this is one of the worst observations that's undertaken in the whole of the NHS, because people like to cut corners. 60 seconds isn't really that long, but actually we need to get a full proper assessment of somebody's breathing. We need to assess them and count that rate over a full 60 seconds. We know that if we look at the rhythm of somebody who's really unwell, it's not always a really nice, even rhythm. Sometimes it's a little bit abnormal. So if you don't count over that full 60 seconds, you may not get the fact that they've breathed in and they've breathed out. They've breathed in and they've breathed out, and then they've had a little long apneic pause before they've taken that next breath. And if you have just counted that respiratory rate over 15 seconds or 20 seconds or 30 seconds and then multiplied it, then you've not got that true picture. And that could be the difference between somebody writing down a rate of 16 and walking away thinking the patient is fine, versus somebody writing down the rate of 8 and going rapidly to get a bag valve mask and support that patient's breathing. It's not a long time, 60 seconds, but it's a 60 seconds that's well worth spending, because the breathing is one of the first indications in a patient that something is going wrong. It's our compensatory method that we can do very, very rapidly. So it's well worth taking that full 60 seconds to look at the rate, look at the rhythm, watch the depth of that breathing. Is it consistent with what it should be for a patient of that size? Because the depth is going to be different in somebody that weighs 50 kilos and is only 5 foot versus somebody who's 6'8" and maybe 100 kilos. And it's looking at that work of breathing as well. Do they look like they're working really hard? Do they look like they're nice and comfortable? So it's thinking about, are they looking as if they're running a marathon and really short of breath, or can they actually talk to you in a nice full sentence? While you're assessing that, it's listening for those added sounds. If you've got the skills and ability, then you can percuss the chest as well. That can be quite difficult in a noisy environment, and not everybody will have the skills to do so. But as alluded to earlier, you can all feel the chest. So you can put both hands onto the chest, onto the lungs, and feel that expansion with each breath to actually see whether it's bilateral and whether each lung is moving evenly. You could palpate the chest in the same process. And it's just considering then, once you've done that full assessment, have you got any other equipment with you? So if you have, then you want to get the saturations as well. If you haven't, then you're looking at the colour of the patient and you're looking for other signs of cyanosis around the lips, around the mouth, to see whether you've got any clue on the saturations of the patient. It's considering, can you optimize the patient's position? If somebody's struggling with their breathing, they're usually going to do far better sat fairly upright. You might find the patient has adjusted their position themselves into sort of like a tripod, leaning forward, so expand their lungs fully at the back. It's considering if you have got the saturations reading, or if the patient looks cyanosed, do you need to start high flow oxygen? We should be aiming for a rate of 94 to 98% in most patients. Obviously, if we know that that patient is at risk of hypercapnia and has a diagnosis of COP with that hypercapnia confirmed by a gas, then we know that high flow oxygen is only going to be good for them in a short term. And then we need to be assessing and titrating it down according to their SATs to a rate of 88 to 92%. However, we also know that hypoxia is going to kill a patient before hypercapnia. So I'd urge you to start that high flow oxygen and actually call for help. And again, it's considering who you need. If you're in the hospital setting, it's pulling that buzzer and making sure you've got people coming, and it's getting that emergency team. If you're not in the hospital setting, it's making sure you've got the ambulance service or the GP or the advanced practitioner coming towards you, depending on what's available to you where you are. It's considering, do you need any extra drugs or nebulizers as well? Because the patient may have things like that in their own home. Can we have the next slide, please? So it's once you've done airway and breathing, it's thinking about circulation. And circulation, again, we're going to use that look, listen and feel technique as well. We're going to use manual equipment where we can if we're getting abnormal numbers. So you're going to look at the colour of your patient, look at how sweaty they are. Are they grey? Are they clammy? Or do they look a nice pink, healthy colour? It's going to listen, if you have the ability, to the heart sounds. And if you have a manual blood pressure, that sort of comes under listening as well, because you're going to be using your stethoscope to actually perform that. It's feeling for that pulse. And again, like the respiratory rate, it's making sure you take that full minute to feel that pulse. You're again looking for that depth, that rhythm, and the volume of that pulse. Is it really weak and thready, or does it feel strong and bounding? And in sepsis, you'll often have a strong pulse when you've not got a very good blood pressure. So the numbers don't always seem to match what you would have in a normal patient. And that's because your patient has really vasodilated. So it's looking at, do the numbers make sense? Do the numbers feel a little bit abnormal? And if you've used automated machines, is it the machine that's broken, or is it your patient that's broken? And that's where using the manual blood pressure, the manual pulse, is far better than using the automated device if you've got an abnormal number. So it's just double checking things manually. It's thinking about the fact of, have we done a capillary refill time? And we can do that peripherally, pressing on the side of the finger, making sure that the hand is above the level of the heart. You press down for 5 seconds and the colour should return in 2. If it's anything like today, my hands are quite cold because the heating's not kicked in, but the summer temperature is also not kicked in. So actually, any deteriorating patient, you're far better off doing a central capillary refill time. So I'd be pressing down on the sternum for 5 seconds and then watching that colour return. And that's normally a warmer part of the body, so you should get a more accurate time. You're going to have a similar delay with vascular patients, somebody who's just washed their hands or they've just come in from the cold. But it's also can be quite difficult if you've got somebody with darker skin tone to see that capillary refill time. So finding that lighter little bit of skin, maybe just on the sternum where they may not have seen quite so much sun, you might be able to actually get a better view of the colour from that point. It's considering, do we actually need to take some bloods? Have they got IV access already? If they have, is it patent? So it's worth flushing that cannula at this point. And if they haven't got a cannula and you're considering that this patient is deteriorating and could be sepsis, then it's making sure that we do blood gases and start the sepsis 6 at this point. Can I have the next slide, please? So after C, you're looking at disability, and we use simple tools like the AVPU, but with new confusion within there. And at each point, this is much, much quicker than a GCS, than a Glasgow Coma Scale. So it's looking at the simple things in your rapid assessment. And if you've got the ability to do a blood glucose, then check that as well, because that's a really easy thing to treat that could be the point of deterioration for the glucose. It's considering, again, do you need help? Can we have the next slide, please? exposure literally does what it says on the tin, doesn't it? It's looking for those reasons. It's looking for that rash. It's looking for any demarcation signs, any skin changes, any injuries or reason for that deterioration. And it's just making sure that we actually start to think about source control in sepsis and think about anything else that we may not have actually considered. And it's just thinking, do I need help, and who that needs to be. Can I have the next slide, please? The soft signs in the community and in some of our younger patients can be far easier for our relatives and our carers and our parents to actually pick up. And this is a great little tool from North Cumbria Health and Care, which was published in 2018, which gives you a nice little prompt of what you could be looking for, or some questions that you can actually ask that relative and that carer to help you with those soft signs, because those are the points of deterioration that don't get picked up on an early warning score. So it's just adding those to your assessment as well. Next slide, please. And do trust your gut. Einstein did, so there's no reason why we can't as well. Next slide, please. It's considering when you escalate that you use a nice tool such as an SBARD to actually structure that communication and make sure that you've got everything in that you need to say, whether it to be the ambulance service or whether it be to a senior clinical review ready in the hospital. The next slide, please. Clearly who you escalate to is going to vary depending which setting that you're in, and it's just considering who you actually need to tell. And it might just be a 222 call, but make sure you've told the nurse in charge so that they know that this emergency is happening on the ward as well. In the community, you might have different escalations, and it's following the escalation for your area, which might be a community hub, an acute care team, or straight to 111 before needing 999. And it's remembering that 112 is also a mobile number that's plumbed in on all mobiles as the emergency number, and is actually quicker to do from your mobile than 999. Next slide, please. And then while you're waiting for that help to arrive, it's just considering, is there anything else that you can be doing? Just think about those extra bits. Do you need any extra tools? Have you screened for sepsis? Have you started that sepsis 6? If they've deteriorated rapidly, do you need to actually use any basic manoeuvres, any adjuncts to help you? If they're in cardiac arrest, clearly you need to start basic life support. And it's just considering, have you optimised the patient's position? There's all sorts of things that can actually help while you're waiting for that help to arrive. And next slide, please. So just in summary, we're using that peer approach to actually prevent that deterioration. If they have deteriorated, then we need to identify that deterioration, and we need to escalate it to the appropriate people and make sure that we've got the right response. And that way we can all save lives. Thank you.
Thanks, Sian. Thank you for that really brilliant talk. There's some great tips in there. We have got some questions for you, but we haven't got time now, so we'll save those for the panel at the end. And our next speaker now is Julie Gowland, who is Clinical Implementation Manager at bioMerieux, our sponsors, and she is their blood culture, and she's going to talk to you about the blood culture pathway. Thank you, Julie.
Thank you, Sophie. If you go to the next slide, please. We're going to discuss the blood culture pathway, why it's important to improve the early steps. Next slide. We're going to go through the importance of blood cultures, the blood culture pathway, important considerations, and I'm not sure we'll have questions. We'll probably save them for the panel. Next slide. The importance of blood cultures. Next slide. Right. Why are blood cultures important? Sepsis can affect anyone of any age and is often treatable if it's caught quickly. Within the hospital environment, there are a variety of tools to support sepsis, including things such as the sepsis 6 pathway and the National Early Warning Score system. Blood cultures play an integral part in the sepsis pathway to ensure detection of the microorganisms, leading to accurate diagnosis and the correct management of infections. This in turn results in improved patient outcomes with reduced length of patient stay in hospital due to improved and quicker targeted treatment of infections. Blood cultures support improved detection rates of bloodstream infections and support using the correct antibiotics, leading to improved antimicrobial stewardship, and reducing the misuse of antimicrobials, which has led to an increase in antimicrobial resistance. Next slide. Blood cultures and bloodstream infections. Blood cultures are the primary diagnostic tool in detecting bloodstream infections. This simple lab test, in which a blood sample is placed into bottles which contain culture media, is able to determine whether infection-causing microorganisms such as bacteria or fungi are present in the patient's bloodstream. Rapid and accurate identification of the bacteria or fungi causing bloodstream infections provide vital clinical information required to diagnose and treat sepsis. Around 100,000 bloodstream infections are detected every year, according to the NHS England 2023 statistics. Next slide. We're now going to look at the blood culture pathway. Next slide. Sorry. It's important that blood cultures are taken as soon as possible after the onset of symptoms for improved sensitivity of the test. However, up to 82% of patients with suspected bloodstream infections are already receiving empiric antimicrobial therapy at the time that the blood cultures are obtained. This could potentially reduce the sensitivity of the test. Recovery of microorganisms may be increased by collecting the blood sample immediately before administering the next dose of antibiotics. Within the bioMerieux fan blood culture bottles, there are resin beads which help to improve antimicrobial binding and have a better chance of isolating the organisms as they can inactivate the antibiotic. Next slide. There are 3 stages in the blood culture pathway. The pre-analytic, which refers to all the actions taken before and up to the loading of the blood culture sample onto the analyzer machine in the lab. We also have the analytical stage, which is what happens within the lab, and the post-analytical stage, which is everything from the reporting to the treatment of the patient with the results. We're going to focus on the pre-analytical stage, which is vitally important to get right and is the initial focus of improvement works. Errors here can profoundly affect the rest of the pathways in ways that can't be recuperated later. Next slide. An effective pre-analytical stage ensures that the results from blood cultures will provide clarity to ensure the most appropriate treatment is provided to the patients. It will also help to reduce the impact of delays and the complications that could result, such as false negatives as the blood becomes less viable due to time waiting or poor volumes. Improved accuracy of the results will lead to improved antimicrobial therapy and reduced antimicrobial resistance. Next slide. Some important considerations. Next slide. So, proper disinfection, sufficient blood volume, and transferring promptly to the lab for testing are all very important parts to remember. Next slide. In order to prevent contamination of the specimen, proper disinfection is important. Each hospital is generally guided by the infection control guidelines and protocols surrounding disinfection of the sampling area. Usually, a skin disinfectant product containing alcohol, which removes naturally occurring oils, allows the water-based preparation to reach and decontaminate the skin surface. The rubber septum of the blood culture is usually decontaminated using 70% isopropyl alcohol. Next slide. Venipuncture is the preferred method of obtaining blood cultures. When taking a blood sample from the catheter, discarding the first 10 ml from the vascular catheter has been shown to have little effect on contamination rates. Central venous catheters have higher contamination rates than peripheral or arterial lines. Arterial blood offers no advantage over venous blood for most microorganisms, but may be superior in detecting disseminated fungal infections. Changing of needles during blood collection is not recommended, as it's likely to increase the risk of needle stick injury and does not significantly reduce contamination rates. Next slide. Contamination of blood cultures can result in diagnostic complications, unnecessary treatment, and ultimately lead to increased cost to the trust. It is important that we reduce contamination through correct skin and bottle preparation. In addition, it's a good education on technique for venipuncture will help to reduce contamination rates. Next slide. Blood volume has been proven to be the most important determining factor in providing accurate results. Even in patients with active infection, the density of bacteria in the blood may be very low. This means there is a chance that the bacteria may not be present or detected within the blood sample. Therefore, you should try to collect enough blood volume for the test to have the best chance at detecting bacteria. For every ml of blood collected, the chance of detection increases by 3%. Additional bottles which are unfilled don't compensate for a lack of volume in each bottle. Next slide. We advise that for an adult that 2 bottles with at least 10 ml of blood in each bottle. If using a winged blood collection set, then the aerobic bottle should be filled first to prevent transfer of air in the device into the aerobic bottle. If using a needle and syringe, inoculate the aerobic bottle first to avoid air entry. If the amount of blood drawn is less than recommended volume, then approximately 10 ml of blood should be inoculated into the aerobic bottle first, since most cases of bacteria are caused by aerobic or facultative bacteria. The labs are able to monitor the volumes collected in the blood culture bottles. How these are communicated back to the clinical area could support in improving practice and ensuring ongoing best practice continues. Next slide. Data regarding the optimum total blood volume per set for neonates and children are limited. The criteria for calculating total blood culture volume is often based on weight rather than age and relates to total patient blood volume. In infants and children, the magnitude of bacteremia is usually higher than it is in adults. Therefore, sensitivity of detection is not significantly reduced by lower blood to medium ratio. Next slide. Blood culture systems are monitored for blood cultures from the point at which the blood is placed directly on the analyzer. For each hour delay to loading on the blood culture and analyzer, there is both a loss of viability of organisms and an incremental delay to obtaining a result. Delays could mean that even if the patient has microorganisms infecting their bloodstream, this is likely to be less likely to be detected and could result in a false negative. Additionally, any delays will cause the temperature of the blood culture to migrate to ambient, resulting in delays to obtaining a positive blood culture. In alignment with laboratory standards, NHS England and NHS Improvement recommends for blood culture sample bottles to be incubated in a blood culture analyzer as soon as possible, ideally within a maximum of 4 hours. In conclusion, it's vitally important that the early steps in the blood culture pathway are carried out meticulously to ensure that the subsequent results are beneficial to improving the patient's outcome and supporting the fight against sepsis. Next slide. I think that's questions.
Thanks, Julie. That was really useful and interesting. Thank you. You managed to sum that up really well in that whistle-stop tour. Right, so we'll have any questions. Yeah, we'll get to those at the panel. Our next speaker is Oliver Jones, who is going to talk about recovery and support for sepsis survivors. He is lead nurse at the UK Sepsis Trust. His talk has actually been pre-recorded, but he will be available in the panel discussion at the end. So please do put any questions into the Q&A box for him and he will answer them then. Thank you.
Hello, and many thanks for inviting me to speak with you today. My name is Oliver, and I'm the lead support nurse at the UK Sepsis Trust. I'm a registered nurse, and I worked in intensive care and acute medicine for about 12 years before joining the charity, about 6 years ago now, to help grow the support service. And what I want to do today is to discuss something that many people, including some clinicians, often don't consider: the what happens next to patients and families when they leave hospital following sepsis, for both those who survive, but also the family members of those that don't. And hopefully, after today's session, you'll have more of an understanding of some of the common challenges that people often face, and what we can all do and the role that we all play in helping to support them. Now, the first thing to note is that sepsis is complex, and I know you've had some other speakers today that have covered the pathophysiology of sepsis and what it is. But I lifted this from a recent academic paper, and it really highlights an interplay between 12 or more various factors, and it kind of reinforces that sepsis is a syndrome, in that we have a group of symptoms all occurring together. And I think it's important we remember this and consider it, especially when we're thinking and talking about how people might feel after the acute phase. And afterwards, people hopefully still don't have sepsis, but what they have is the consequences or collateral damage. And it's also worth noting that sometimes the lines can be really blurred, really, between, well, where does uncomplicated infection stop and sepsis start, or where does sepsis stop and septic shock start? And it is complex, and we know that people can present often anywhere on this continuum. We know we get some very sick people presenting at A&E, but people can present with an uncomplicated infection that might be high risk of then deterioration. But we know the further along the line, the higher mortality rate, and also the increased morbidity. And I think that's really important to remember. The morbidity referring to the suffering, if you like, that experienced as a result of sepsis. So the further along that line, not only does the mortality rate increase, but also what people might experience afterwards. And also, it's also worth noting that the severity of disease does not always dictate what people might experience after. And is survivorship enough? You know, we speak to and support thousands of people each year, and yes, most of those people we speak to, not all, most of those people we speak to are happy they survived. But lots of people will go through an often protracted and complicated recovery journey. And for most people, it's a life-changing event. And people will often say that the real journey begins once they get home and once they leave that acute hospital setting. Now, as mentioned, and as you've probably heard already today, sepsis is complex. And our understanding of the recovery side of things is also complex and largely incomplete. And it's explained largely by changes in the microcirculation that will lead to cellular hypoxia and ischemic changes in our tissues and organs. And in sepsis, we get a large acute inflammatory response in that acute phase, but then we also get an anti-inflammatory response for some time after. And that immunoparesis or immune system stunning is likely to contribute to the reinfection risk post-sepsis, with evidence suggesting that both 30 and 90-day readmission rate to hospital following sepsis is high compared to other conditions, with the number one reason for readmission being infective complications or sepsis. And the problems people experience are largely due to the sepsis itself, so that underlying disease process, what's happening when someone has sepsis. But it's also compounded by lots of other things, and it's a perfect storm, really. And I say this every day on the helpline to the people we speak to, and sometimes people have to be reminded, you know, being in hospital is bad for you. A hospital stay will commonly include physical deconditioning, you know, medication, malnutrition. Most people leave hospital in a worse nutritional state than when they went in, sleep deprived, and a psychological trauma. So the nature of being in hospital is bad, and then we add in the sepsis, and it's a perfect storm. And evidence will tell us, not always, but the longer the hospital stay, the worse the outcome. And for those people who have an admission to critical care also. And part of the problem is it's not a one-size-fits-all process. There are really lots of variable factors, and that will commonly include things like people's age, pre-existing health, and length of hospital stay. And there are always exceptions, as previously mentioned. Evidence will say severity of disease does not always dictate what people might experience afterwards. And the problems that some people can experience be broken down into 3 different groups. So we have the physical problems, the cognitive problems, and the psychological problems. And some of these might be more obvious to you. Most clinicians will think, well, yes, people who have a prolonged hospital stay are probably going to leave with some physical conditioning, and muscle weakness and muscle wastage. But some might be less so, particularly the hidden ones, the cognitive and psychological consequences. Because we can't see them, they're often not talked about and they're often overlooked. And those are as important for people as the physical problems that they may experience. So it's really being mindful, and it's not just those things that we can see that are potentially going to cause people problems afterwards. And it's not just the people who go through these doors of critical care. About 40% of the hundreds of people we support each month haven't had an admission to critical care, but will often experience the same problems as the people who do, which, as mentioned, suggests it's not just severity of disease that will dictate recovery. And if we think about it, we're very good now and getting good, much better at treating some really, really sick people on the ward. And so hopefully they might not require critical care admission. We have critical care outreach team services who can help stabilise the patient, start appropriate treatment, and maybe they might not need admission to critical care. And hopefully that demographic of patients is going to grow as we get better at treating sicker people on the ward. But it's not just those patients who go through these doors of critical care that are going to potentially experience problems in their recovery. Now, some of you may have heard of the term post-sepsis syndrome, and it's really an umbrella term, really, and it describes a variable set of ongoing problems that people might experience for a period of time after sepsis. And part of the problem is there's no internationally agreed definition, or ICD, International Classification of Disease Code, for post-sepsis syndrome yet. Hopefully in time, and that's a problem, because having that would be really helpful for awareness, validation, but also then future commissioning of services and research. Now, some of you may have heard of post-intensive care syndrome, and there is some crossover certainly, but we know, as mentioned, we know a lot of people who experience problems post-sepsis haven't been in intensive care, so that term is not going to be applicable for those people. So what does the literature say? Well, there's lots of literature, particularly in the last 15 years, that will show a new and lasting morbidity is common after sepsis. And these will commonly include 1 to 2 functional limitations, a 3-fold increase in moderate to severe cognitive impairment, a significant increased risk of hospitalisation, as mentioned, and just over half of people previously working will return to work in 6 months. And I wanted to share this with you. This was from a recent and important review that was published in the Infection and Drug Resistance Journal, and research has really delved into the current knowledge of post-sepsis syndrome, and it shed a light on some of the lingering consequences of sepsis that extend far beyond the initial illness. And it highlighted a variety of things, but most importantly, that 3/4 of sepsis survivors develop at least 1 new diagnosis after hospital discharge, and that only half achieve complete or near complete recovery within 2 years, and 1 in 6 will carry on experiencing persistent symptoms. So the long-term effect is often not given enough time. And this is reinforced by some of our own research that we've done, and most recent in 2024. And we had over 3,000 responses in just 2 weeks. And some of the headline stats from the survey were, not new to us, but it might be new to you. So as mentioned, about 40% didn't have an admission to critical care. Worryingly, about 70% left hospital with no information about sepsis recovery. And 18% of those 3,000 people were left permanently unable to work. So what can we all do? What role do we all play to enhance people's recovery? Well, the evidence tells us we have 3 opportunities to make a real difference. Number 1 is that pre and early hospital care. So we know evidence will tell us the earlier we start people's appropriate treatment, not only improves their mortality rate, but also their morbidity. Ongoing hospital care, lots of really good evidence around early mobilization of our patients, appropriate sedation hold, getting our patients moving, and that de-resuscitation where appropriate. And then number 3, that post-hospital care. Information on discharge is one of the most common things that people will say to us, that it would have made a massive difference if I'd have just been given some information, some signposting into organisations that might be able to support me and provide some guidance. It makes a massive difference. And as I said, we also provide bereavement support to those affected. And this statement is something that we commonly hear from people. The speed that people might have deteriorated and died as a result of sepsis, it's like their loved one has died in a car crash. They might have been having breakfast with them a couple of days before, or dinner, and then 2 days later they're not here. The severity and the speed in which people can deteriorate is frightening. And for many people, the first time they might see the word sepsis or hear the word sepsis is when they read it on a death certificate. So we're there to help fill in those blanks for people and to provide some emotional support, one-to-one support with one of the nurses, and also help them connect with peers. We're a small and hugely enthusiastic team, and we all have a very similar background when it comes to intensive care nursing and working in a hospital setting. And it's never been easier to get in touch with us. We have a nurse-led helpline which is open Monday to Friday. People can contact us via email, or we have dedicated Facebook groups that are moderated by me and the team as well. So it's never been easier for you to reach out to us if you want to, or for your patients or families as well. And we help. It's quite simple, really. A lot of the support we provide is providing that real listening ear to people, giving people time and space to ask questions, to share how they might be feeling, and we can validate them and normalise that actually how you're feeling now is appropriate and quite normal. We provide information and resources that might help enhance people's recovery and grief journey. We help people to help manage their own expectations and other people's expectations, and we give hope and encouragement for the future along the way. I mentioned our resources. We have a suite of free digital resources and paper resources as well that you can use, or you can signpost your patients or families to. One of those, which is one of our most popular, is our recovery diary. So evidence will say if we can chart our recovery, it helps us identify the progress we've made, but then also identify any worrying areas or areas of concern we might need to highlight up to healthcare professionals. We help to facilitate a number of peer support groups as well. We have some face-to-face groups around the country, but then we also have a number of weekly online groups, both for those who have survived sepsis, but then also those who are bereaved. And we also have, as I mentioned, our peer support groups on Facebook as well. So just to reinforce, how you can really help your patients, listening to them, listening to their relatives. Tell your patients they've had sepsis, that they've been treated for sepsis and diagnosed with sepsis. Tell them that's what they've had. Find an explanation of sepsis that works for you in your setting. Sepsis is quite complex, and trying to understand it is quite complex. So find something that really works for you and signpost to us to help you. We know how busy you are. So signpost to us if we can help take some of that workload off you. Thank you very much for your time, and If anyone would like to contact me offline, you can use our email address or our helpline number, and I'm going to be around for the panel discussion as well. So thank you very much.
That was great. I hope you all found that useful. I'm glad the tech worked. We're now into our comfort break. Because we're running a little bit behind, we're only going to have a 3-minute comfort break. So if you can be back here in 3 minutes for our final presentation and Q&A panel, that would be fab. So see you back here in 3 minutes. Thank you. Welcome back to our sepsis webinar after that very short break. Now, before we get to our Q&A panel, we have one final speaker, and that is Vanessa Sweeney, who is Chief Nurse at University College Hospitals, London, and a member of Martha's Rule Oversight Committee. And she's going to talk to you today about how to challenge decisions effectively and raise concerns, including the implications of Martha's Rule. Thank you, Vanessa.
Many thanks. It's a real pleasure to be here today, and I'm looking forward to giving you a bit of an update on Martha's Rule and what the implications are in practice. Just moving on to the next slide, and the next one. Thank you. So I want to tell a little bit background first and what the drivers are for Martha's Rule before it's come into place. And I think you've probably heard some of this today from previous presentations, but I think it's a fact that we need to keep coming back to, that we have over 265,000 deaths following admission to hospital every year, and it is understood that 3% of those deaths had at least a 50% chance of being preventable. That is a really significant and stark fact, when that equates to nearly 8,000 people whose deaths could have been avoided. And when you really break that down, that is 5 deaths a month at every trust, and that's significant in terms of that. There have been various investigations and evidence examining this, and one of those documents came from the Parliamentary and Health Service Ombudsman report entitled Broken Trust and Making the Patient's Safety More Than Just a Promise. And one of the key factors that came from this document and from this investigation was failure to listen to concerns of patients or their families was a key factor. As we know, there have been a number of investigations over recent years that have been quite high profile, going right back to the Francis inquiry, and then leading up to the Ockenden report into maternity care and others that are related. The focus is really on improving the reliability, and that really comes through in this document around how do we improve the reliability in relation to acute deterioration pathway. So thinking about observations, recognition, the patient voice, and escalation and response. So just moving on to the next slide. Why is this important? Well, those are the numbers, and then these are the people. So there have been a number of high profile cases that have identified where there have been failures in care, where patients have attempted to escalate concerns about their own well-being and their own deterioration, but have not had the response that would be expected. And that latest high profile case relates to Martha. And has led then to the work that we hear now. But the cases of Kane Gorney, Evan Smith and Maddie Lawrence are all equally significant in terms of the implications. So just moving on to the next slide. In the lead up to the implementation of Martha's Rule, there was a significant improvement collaborative that has been running for the last year or so across England. So this was called the Worry and Concern Quality Improvement Collaborative, involving 7 regions and pilot sites across 2023 and the early part of this year. And the purpose of this collaborative was to test reliable methods for patients or their families and carers to 2 aims. One, to escalate worries and concerns about acute illness and deterioration. So when standard care is failing them, how do they escalate? And the second aim was to routinely input their views about their illness and any worries or concerns into the health record. So that became part of how we evaluate their care. Alongside this, and I've referenced this here, NHS England commissioned the Florence Nightingale Foundation to examine the barriers which prevent worries and concerns being raised. And they found from their investigation 3 key factors that were contributing. So organisational culture, professional hierarchies, and the nature of leadership within healthcare environments. And the findings highlighted the importance of psychological safety. And they recognise that to achieve psychological safety, it's highly influenced by certain types of leadership. So authentic leadership is really key to overcoming those barriers. And the components of authentic leadership are transparency, integrity, and leaders who demonstrate authentic leadership will tend to be very self-aware, use emotional intelligence, and lean really into the more relational components of leadership in their approach, with a strong focus on engagement. So the Florence Nightingale Foundation, examining this, what influences leadership, culture and hierarchy, not only demonstrated what was challenging, but really identified where we could move forward positively in terms of leadership. So moving on to Martha's Rule. So just moving on to the next slide. So the Worry and Concern Collaborative has really informed how Martha's Rule has developed. So this gives us an idea of the evidence base that's informed this approach and taking this forward. So just a bit of background, I'm sure many of you will be aware, but Martha Mills died in 2021. She was being cared for in a large London teaching hospital, and she died after developing sepsis in hospital. Her family had raised concerns about her deteriorating condition, but were not responded to. And there's a lot of detail that describes what that looked like and the relationships between clinical staff that fed into this and into the next stage. And then in 2023, so last year, a coroner ruled that Martha would probably have survived if she had been moved to intensive care at an earlier point. So it was really in response to this and to the cases that I've mentioned previously and others that there was a commitment made to roll out Martha's Rule. And the whole concept is about giving patients, families and carers round-the-clock access to a rapid review from a separate care team if needed, and to also ensure that their voice is part of the care plan, the care treatment and the evaluation of care. So the implementation of Martha's Rule has begun, and it started with the first 143 hospitals that are in the first wave, and all of those hospitals that are taking part in this stage of Martha's Rule rollout all have 24/7 critical care outreach capacity. So that was the criteria for this first wave of bringing in Martha's Rule. Those in this first tranche will be focused on over this year and next year. So it's about 18 months that we'll be doing this review and evaluation, and really focusing on supporting organisations to devise and agree a standardised approach to all three elements of Martha's Rule. So over this next 18 months, there is an evaluation, so research running alongside this, as well as all of the organisations being part of a collaborative and informing the best way to roll this out nationally. So it will inform those components. So what is Martha's Rule? There are three key elements to this. The first one I've already mentioned is that all staff should have access to 24/7 critical care outreach. The second component is that all patients, families and carers should have the same access to that 24/7 critical care outreach. And then thirdly, the final component is that the NHS must implement a structured approach to obtaining information relating to a patient's condition directly from patients and their families at least once a day. And in the first instance, and this is part of that first wave, this will focus on all inpatients in acute and specialist trusts. That doesn't mean that in the later stages that won't involve community and wider specialties as well. That's the aim. So just moving on to the next slide. In other words, the Martha's Rule recommendations are that all staff, patients and families have 24/7 access to critical care outreach if they are concerned about a patient. If their escalations locally are not being responded to, then we must be able to raise those concerns with critical care outreach. And then secondly, we should have a structured approach to obtaining information related to the patient's condition, and be able to do that at least daily. So just moving on. I thought this is quite wordy. I'm not going to go into the detail, but I thought it would be helpful when these slides are shared to include the joint statement on Martha's Rule that came from the Nursing and Midwifery Council, General Medical Council and the CQC, the Care Quality Commission. I think it's important from a leadership perspective that we see that this doesn't affect just nurses or just doctors, but this is about the whole professions that care for patients directly, the whole multi-professional team, and that this is about focusing on care that is person-centred and responsive and really aligns to those very high professional standards that we have across all of our professions. But I think what's really important here in this statement is the focus on effective teamwork, mutual respect and open communication. So culture. Culture was a key factor that affected Martha Mills' outcomes and is a common thread across other cases. So this has to be a really important aspect of rolling out and understanding how we implement Martha's Rule across organisations, how we focus and centre in on culture. So a key part of culture is communication. So I'm just going to touch now on the barriers and the enablers to communication. So just moving on to our next slide. So there are many things that we could look at, but there are just a couple of areas that I want to touch on in terms of communication barriers. I think firstly, nursing knowledge and skills. That will affect, as nurses, our ability to communicate effectively patient deterioration. So not having the right level of knowledge and skills in terms of identifying deterioration will be a key factor. How we understand and implement news too, and how we then provide that skilled communication to escalate to our colleagues at that key point when they're not present, and even if they are present, in a way that will connect and recognise the needs. So obviously days like today have a significant impact on improving our knowledge and skills, but as professionals this is a key responsibility to take forward, to have the right level of knowledge and skills to be able to identify deterioration. A second barrier that I wanted to highlight that affects communication is task-orientated care, and this is something across the nursing profession we talk about a lot and have done for a very, very long time. We know that task-orientated care reduces key aspects of care that we provide to patients to tasks, and that reduces the quality. So once we start to impact how we deliver care and moving away from that holistic approach and that person-centred approach to task-orientated care, then we start to affect the quality of care that we've delivered. And I popped that phrase in there, doing the obs. There is a lot of aspects of care that gets reduced to these statements and tasks that then affect how we communicate between each other. There is also the aspect of devolving roles of assessment from the registered nurse to our healthcare assistant colleagues, which is obviously perfectly acceptable working within teams, but it's really important for us to recognise what is appropriate to devolve and what is important as registered nurses when we're looking after acutely unwell patients. What do we hold as part of our role of patient management? Often we can find that communication between healthcare assistants and registered nurses will affect the communication of patient observations and key aspects of care. There are examples, and we've seen this in investigations, where there has been a delay between healthcare assistants recording or taking observations and communicating those, whether that's recording them in the patient notes or communicating them to the registered nurse, who is the named nurse for the patient. So really understanding those factors that can be barriers to communication when we work in teams across professions is really key, and there are opportunities to look at that differently. Multi-professional culture, so taking this wider than nursing and thinking about our wider teams, so our medical colleagues, AHP colleagues, there can be a hierarchy between and within professional groups, and documents that I've referred to and investigations that I've referred to have highlighted that this is a key factor that impacts on communication and effective communication. So hierarchy within the nursing profession, but also within the medical profession, can delay and prevent escalation. It can create a fear of escalating, of disturbing people, of barriers that have been created around that escalation, and prevent people from being able to communicate in a way that that is in the interest of the patients. I've also highlighted here language barriers between professions. So as nurses, we have our own language. Doctors have a slightly different language. AHPs talk in a slightly different way, as do pharmacists. So we use different terminology and we have a different understanding and nuance for different factors. And it's really important that we know and understand each other's language and what will connect between each other. And with that, there can be a lack of understanding of each other's roles and responsibilities. As nurses, we provide continuous care for patients within a ward or department setting, but our colleagues, medical colleagues, particularly in HPs, their care is more episodic. They're not necessarily always present and not continuously looking after one patient. So really understanding that a medical colleague may be working across a number of wards or different departments and may not be readily available. It's really important to know and understand that. So if we're communicating an escalation, understanding how we help our colleagues to prioritise that is key. So I think some of these are the key barriers, and I've kind of grouped them under nursing knowledge and skills, thinking about task-orientated care and that multi-professional culture. And there are many factors within each of those that really affect our communication. So what enables effective communication? So just moving on to the next slide. Nursing knowledge and skills. So being skilled in the delivery of our care, being able to identify deterioration really effectively through skilled patient assessment is key. Recognising as nurses that we have critical thinking skills. So thinking about that holistic approach to care takes that level of safety and quality to a different level. A strong and effective understanding of news too, and SBAR to structure escalation helps consistency. It reduces some of that variation, and particularly when we're stressed. And invariably, if we're escalating care of a patient, it's in a difficult situation where we're looking after someone who's deteriorated, and having that structured way to escalate promotes that consistency. I've mentioned culture, so an enabler to really effective communication is a strong, positive, multi-professional culture, and there are ways of achieving that. So creating training opportunities together as an MDT. In many occasions, we all have our education and training and study days separately. There are now more and more opportunities where doctors, nurses, AHPs, pharmacists are training together, are learning together within ward teams and across specialties. And this should be very much encouraged. When we do this and we learn together, then teams develop together. We get to understand each other better. We get to create that shared language and understanding, and we build relationships. And that relational component is so important to a strong multi-professional culture. Nurturing team values that focus around safety, really great teamwork and kindness are key aspects of developing a safe culture, a culture that is focused around the patients and the quality of care that we deliver. And with it, nurturing psychological safety. If a team has really strong values that are bring a team together and promote multi-professional working, where teams learn together, you start to then develop and nurture psychological safety. And this includes then strong leadership, but also teamship. And teamship is an area that I think, when we're talking about how we support positive communication within teams, we need to nurture teamship. We talk a lot about leadership, but this is an area that we can all contribute to and make a difference. And then another aspect is staff well-being. None of us are our best when we're tired, when we're hungry, when we're stressed, when we feel we're not working in the right environment. So thinking about staff wellbeing, really understanding what will make a difference to teams and their development is key. And then finally, on that point, person-centred care. So bringing the patient voice in, really involving patients in decision making is a key aspect. So key aspect of Martha's Rule, but a really key aspect to nurturing patient-centred care, person-centred care within our environments. And when we think about that third component around Martha's Rule and how we implement that, really thinking about how we use the patient narrative, not interpret what the patient has said, but really quoting them in their own words and thinking about our next colleague that then reads that note will then see that from that patient's perspective. And it's a key way to be able to communicate exactly how the patient feels in their way and their voice. So just moving on to the last slide. In all of this, it is really important as professionals that we recognise and value our unique contribution to this whole aspect of preventing deterioration and really delivering safe and quality care that is person-centred. We are a safety critical profession with a huge level of knowledge and skill and expertise, both within the delivery of care, but wider than that, how we provide holistic care for our patients. The definition of nursing is relational. It is within, if you look at our definitions, very much within there. How we relate to our patients and their families is absolutely critical, and it is one of our key attributes and something that should be nurtured and developed as individual nurses, but really bringing that out within our teams as well. We are reflective practitioners and critical thinkers, and we can bring all of that into how we deliver care. I think recognising that we are the one profession within a hospital setting and often a community that have that continuous presence with patients and families and carers. So we're acquiring a huge amount of knowledge and understanding about those individuals that we are caring for and taking care of. So we can advocate, and often people don't like the word advocacy, but this is a real opportunity to ensure that we're empowering our patients and their voice in their care. And we can do that in so many different ways, whether it's the one-to-one and when we're carrying out patients' observations and that aspect assessment, or whether that's part of a ward round or within the ward round or within our MDT meetings. We can bring that patient's voice, their views, their worries and concerns into our everyday practice, and really thinking about person-centred nursing practice, holistic assessment, holistic delivery of care that is focused on that individual. And as I said, bringing that patient voice in. As nurses, we develop our leadership skills very early on, and this is an opportunity within ward teams and departments to really set the tone for the team. How should care be delivered within your wards? How do you want your teams to work and to lead care for the patients? Building a team that has the right skills and attributes is really key. So leadership and setting that tone is really important. And as I mentioned, teamship. There is real opportunities every day for us to bring out the best in other professions and in each other. And this is a really key leadership attribute. And this is something you develop as you go through, but really important that we do bring out the best in each other, that we understand each other's roles, and that we have the patient then very much at the centre. And bringing all of these factors together is the real opportunity to then take all of that knowledge and skill and expertise, that you've learned today, that you're continuing to learn around this key area, and bring that into our practice and really focus on how we nurture a culture that allows our patients to have that strong voice within the care. I'll leave it there. Thank you.
Vanessa, thank you so much. I'm afraid we couldn't see you, but we could hear you loud and clear, and it was so vital to hear how leadership and organisational culture can impact patient outcomes and what nurses can do about it. So thank you very much. I'll move swiftly on. We've only got kind of 11 minutes left, so I'm going to move swiftly on to the panel discussion and Q&A. We've had quite a lot of questions coming in, so what I'll do is I'll try and target them at you, panel members. All the speakers are in the panel. We also have the addition of Ian Fraser, who is a blood culture best practice ambassador at bioMerieux, who will be joining Julie to help answer questions. So first of all, I'll go to you, Sian, if that's okay. So one question that came in for you was, neutropenic patients may have a NEWS 2 score of 0. Under the new guidance, does that mean that they are not eligible to receive sepsis 6 bundle within the hour?
Not at all. We know that neutropenic patients are often not going to trigger on the early warning score, because potentially the most they'll trigger is a 1 or possibly a 2 with their temperature. So you have to have some clinical intuition, some experience to build this in as well. We've got a safety net within our trust that when you do your vital signs, there's another couple of questions added on the bottom, and one is healthcare concern and the other one is the patient wellness question for Martha's Rule. So we would be asking the question of ourselves as the healthcare professional, are we concerned? And in this case, with a high risk patient, risk of neutropenia, I'd be clicking that button, and basically it allows me to get that senior clinical review within the hour and get them to come and prescribe and treat that patient. But the Martha's Rule button will also do the same within our trust.
Thanks, Sian, that's brilliant, thank you. One here actually, which is quite short and sweet, but for you, Vanessa, does Martha's Rule apply to Scotland as well?
Yeah, I think there's a question about Scotland and Wales. I think at this stage it's being rolled out across England. NHS England is leading this. So that's where we're at the moment, but I suspect as it is evaluated in this first year, there will be learning that will be taken forward and impact across.
Brilliant, thank you. Another question here. So it was highlighted earlier that 75% of patients develop sepsis in the community, which would include nursing care homes. Shouldn't sepsis be part of mandatory training in order to improve the quality of care for all residents and patients? Perhaps, Oliver, do you want to maybe take that one?
Yeah, no problem. Short answer is yes. And probably find that it is included in some way in some form of training, induction training. But yeah, I very much advocate for sepsis being included in some mandatory training, certainly.
Thank you. I think this one might be good for Julie and Ian, to identify the line infection. The blood culture from the catheters, like PICC and midline, will be done. Do we still need to discard 10 ml, or the first bloods need to be sent?
Yes, I would still say people need to discard the first 10 ml, but everyone will have their local guidelines, and you would be advised generally to follow what your local guidelines are for the trust.
Thank you. That's great, thank you. And I think maybe Suman, this might be a good one for you. Most of the time, antibiotics get started in just-in-case circumstances while waiting to hear from microbiology. How can that be avoided? Is there anything that can be done before considering antibiotics?
And that's a really great question, and one of the clinical conundrums, to be honest, because we do practice defensive medicine these days. We like to be seen to be doing things. But that's the whole purpose of the new NICE guidance and the Academy of Medical Colleges guidance, is to avoid that. Because if the patient is really, really sick with a new score of 7 and a likelihood is infection, then those patients are actually quite clear cut, because normally rapid response teams are there, medical registrars are there, and that's fine. But those patients who are the one the questioner is asking is those who are not that sick, but they've got potential to be sick, and they will be usually in a kind of moderate sort of risk category. And this is why the NICE guidelines gives you that 3-hour window to give antibiotics, so that you can get a senior review, have a proper investigation to confirm whether the reason for deterioration is infection before you give antibiotics. So this implementation of new guidance will hopefully avoid this sort of clinical problems and issues.
Thanks, Suman. That was a great answer. Thank you. Here we've got someone asking, is drawing blood culture from central line, could that affect the result? Is it better to draw blood culture from a venipuncture than from a central line? I don't know who would like to take that one. I don't know, Sian, do you want to answer, or?
Yep, I can do. Effectively, within our trust, if you have got a central line, we would actually want both peripheral and central cultures, because we would want to know whether you've actually got a problem with the line itself. And if you've only taken blood cultures from the line and the line is infected, you don't know if it's only the line. So if you've taken the peripheral ones, then you know if it's a systemic problem as well. So we would certainly advocate taking from both, but I would follow your local trust guidance on that one.
Thanks, Sian. Thank you, Sian. We've got a few blood culture questions here, actually. Number 1, how frequently should we take blood cultures? We normally would just ask doctors, and typically we wouldn't take blood cultures if they had been done in the last 24 hours. But is there a set rule or recommendations? Who'd like to take that one? Anyone, if anyone wants to shout in, please do.
Yeah, I would like to make a note, and whilst it's not related to frequency necessarily, always follow your local guidelines, but typically 2 sets of blood cultures should always be taken. Some laboratories, unfortunately, are struggling with capacity, especially since the new SMI guidelines came out for microbiology investigations. So whilst it's not frequency, if you can take two sets of blood cultures, then certainly do so. The volume of blood, whether that be over 1 set or two sets, is directly proportional to the recovery of organisms. I hope that helps.
Yeah, that's great. Thanks, Ian. That's great. There's another question here about cultures as well. Does having IV paracetamol affect blood cultures taken? I don't know, Ian, if you want to answer that as well while you're on it.
So I mean, there's nothing. Always check your kit inserts. So regardless of whether you're using bioMerieux bottles or you're using BD bottles, do check the kit inserts for anything that could, affect the integrity of the sample. But generally speaking, paracetamol, no, that isn't going to make any difference to the blood culture.
Thank you. Thanks, Ian. That's great.
Thank you.
Suman, one here for you, I think. Should care homes record vital signs daily once a resident who is discharged back to the care setting, where they restore to, or just, sorry, I'm just reading these as they're coming through, or just respond to soft signs as before, only because you mentioned the risk of readmission 30 to 90 days post sepsis? Sorry, I'm not sure who mentioned that, actually. I don't know.
No, I didn't mention that, but I think it's a good practice to do this. I think there is a more and more conversation happening at the moment around utilization of News2 across the system, across the settings. Predominantly it used to be in the hospital settings. Now the ambulance services use them. Now the GP practices are starting to use them as well. And I think it is a good practice to actually use in the care home settings as well. But there is a caveat to this in care home settings, because the News2 score it still presumes that your physiology, whether you are 18 years old or 99 years old, you have the same physiology. So there's that, you know, downside of this. But I think we need more studies around using news2 in sort of care home settings. I don't think it's really clear cut that it's actually indicative of any sort of clinical deterioration as such, because, you know, it depends upon the sort of morbidity sort of state of the individuals in the care home, really. So what underlying background they have. But I think to have a baseline is probably a good idea, to have a, you know, a vital observation. So when they come to A&E, if their normal blood pressure, for example, is usually, you know, 90-95, then, you know, our colleagues in A&E don't start to sort of panic when their blood pressure is systolic 90. So yeah.
Brilliant, thanks, Suman. Thank you. I realise I'm firing these questions off. We're running out of time, so I'm trying to get as many out as possible. Another one here. For Sean, this was, how much unprescribed IV fluid is a nurse allowed to administer in a case of suspected sepsis?
The short answer is none. If you are not a medical prescriber and you don't have the ability to use a PGD and there is no fluids prescribed, then legally you cannot give those fluids. What you can do is you can get the giving set out and the fluids out ready, and as soon as you've got a prescriber there, you can give what they ask. But the short answer, I'm afraid, is none.
Okay. Thank you. Thank you very much. I'm afraid we've run out of time. It's 2 o'clock. So thank you so much for all the questions. I'm sorry we didn't manage to get to all of them. Thank you very much to all our speakers for joining us today and giving up your time. And thank you to bioMerieux for sponsoring today's event, and for all you attendees for coming today. There were quite a lot of you, over 1,000. Wow. So I hope you found it really, really useful and valuable information for you to take back to your practice. And the webinar has been recorded and will be made available on our website shortly. So thank you very much to everybody, and I hope you have a great day.